Welcome to the Deep Dive. Today we're tackling a really foundational topic in medicine, neuromuscular blockers. Think of this as, building a solid base,
Right.
especially if you're following along on KMR advice.
Exactly. These are drugs you'll definitely see used a lot. Anesthesia, ICU, even the ED sometimes.
Right.
So our goal here in this deep dive is to pull out the key info about them. We're using that Neuromuscular Blocker Essentials document you've got access to.
The one uploaded on KMR advice.
That's the one. Think of this as a sort of lecture discussion tailored for your learning on KMR advice. We want to get clear on the types, how they work, and the really important clinical points.
Sounds good.
And hey, if this helps you, please do share it around, subscribe to KMR Advise, and, hit that bell icon. Helps you not miss out on future content.
Definitely. And just so everyone can follow easily with their KMR advice material, we're going to stick to the order in the document.
Good plan.
So uses first, then classification, mechanisms of action, how they work, pharmacokinetics, those clinical pearls.
Yep.
Adverse effects, contraindications.
Drug interactions, dosage, pediatric stuff, toxicity, and wrap up with key exam points.
Perfect. Let's jump in.
All right, so uses. Where do we see these most often?
Well, they're incredibly versatile. One huge area is endotracheal intubation, getting that breathing tube in.
Right.
And succinylcholine, because it works so fast, is often the classic choice there. It's a depolarizing agent, especially when you need that airway quickly.
That speed must be crucial sometimes, and for surgery, when you need muscles relaxed.
Yeah, absolutely.
Yeah.
For surgical muscle relaxation, you'll often see the non-depolarizing agents, things like rocuronium or vecuronium.
Yeah.
Then think about the ICU, patients on ventilators. An agent like cisatracurium can be really helpful there, helps the patient synchronize better with machine, and it tends to have less histamine release, which is a plus.
Less histamine release. Good.
And interestingly, acetylcholine pops up again in ECT, electroconvulsive therapy.
Oh, it helps prevent musculoskeletal injuries during the induced seizure, makes it safer.
Wow, okay. So OR, ICU, ECT. Quite a range. Are there other, maybe less common procedural uses?
Yeah, good question. They're useful in things like orthopedic manipulations.
Like setting a bone?
Exactly. Getting that muscle relaxation helps reduce fractures or dislocations. And also sometimes during laryngoscopy or bronchoscopy, looking down the airway.
To keep the patient still.
Precisely. Gives the doc a better view, makes it safer.
Okay, that makes sense. So quite broad utility. Now, let's shift to how we classify them. You mentioned depolarizing and non-depolarizing.
Yes, that's the main split. Depolarizing agents and non-depolarizing agents.
And the main depolarizing one is?
Succinylcholine. That's really the key one in that class. In India, you might see it under brand names like scoline or enectine.
Okay, scoline, enectine. Got it. And the non-depolarizing group, it seems like there's more there.
That's right. The non-depolarizers are split further based on their chemical structure.
How so?
You've got the aminosteroids. That group includes rocuronium and vecuronium.
Right.
Brand names you might see in India could be like Esmeron for rocuronium, Vecuron for vecuronium.
Esmeron, Vecuron, aminosteroids.
And the other subgroup is the benzylisoquinolines.
Benzyl isoquinolanes.
Right. And that includes cisatracurium and atracurium. Common brands might be Nimbex and Tracium.
Nimbex, Tracium. Okay, so two main types, depolarizing and non-depolarizing, and then the non-depolarizers split into aminosteroids and benzylisoquinolanes.
You got it.
Now, your notes, the KMR advised document, it really emphasizes the difference in how they work, the mechanism. Let's unpack that.
Yeah, this is fundamental. It all comes down to how they interact with the acetylcholine receptors at the neuromuscular junction.
Okay.
So depolarizing agents like succinylcholine, they actually mimic acetylcholine. They bind to the receptor and cause it to depolarize.
Like flipping the switch on.
Exactly. But here's the key. Acetylcholine isn't broken down quickly like normal acetylcholine is. So that depolarization persists. It hangs around. This initially causes those little muscle twitches, fasciculations.
We mentioned those earlier.
Right.
Yeah.
But because the membrane stays depolarized, it can't repolarize to fire again. So paralysis follows. That sustained depolarization is called a phase block.
Okay, so it mimics the on signal but gets stuck, leading to paralysis. What about the non-depolarizers then? Rocuronium, cisatracurium?
They do the opposite, basically. They are competitive antagonists. They bind to the same acetylcholine receptors, but they don't activate them. They just sit there and block acetylcholine from binding.
So they just occupy the parking spot so acetylcholine can't park there?
That's a great analogy, yeah. They prevent acetylcholine from doing its job, so the signal to contract never gets through. This leads to what we call flaccid paralysis. The muscle just can't be activated, no initial fasciculations, and this is generally called a phase 2 block mechanism.
Got it. One jams the signal on, the other just blocks the signal entirely. Much clearer. The notes also flag that rocuronium is pretty fast acting for a non-depolarizer.
Yes, that's a really important clinical point. Rocuronium usually starts working within, say, 60 to 90 seconds.
That's quite quick.
It is. It makes it a useful alternative to succinylcholine, especially if you need rapid sequence intubation. But maybe succinylcholine isn't safe for that particular patient, for reasons we'll get into.
Interesting. Sort of bridges the gap speed-wise. Okay, let's dig a bit deeper into that mechanism of action. Step 1, receptor interaction. We've kind of covered this, but just to solidify.
Right. So succinylcholine binds nicotinic ACE receptors, causes that persistent depolarization, fasciculations first, then paralysis.
And non-depolarizers, rocuronium, cisatracurium.
They bind the same receptors but block ACE. No depolarization, just prevention of the normal signal, leads to flaccid paralysis.
Okay. Step 2, clinical effects. What do we actually see happen?
With acetylcholine, those fasciculations happen fast, like 30, 60 seconds after you give it, then boom, paralysis. But, and this is key, it's usually very short-lived, maybe 5 to 10 minutes total duration.
Wow, that is short. Useful for quick procedures, I imagine.
Exactly.
Yeah.
Now, non-depolarizers, the main effect is just that flaccid paralysis. No fasciculations generally. And how relaxed the muscles get and for how long really depends on the dose you give.
Dose dependent. Makes sense. Okay, step 3, termination. How does the effect wear off? How does the body get rid of them?
This is where they differ quite a bit again. Succinylcholine gets broken down very rapidly right in the blood plasma. Yeah, by an enzyme called plasma cholinesterase, sometimes called pseudocholinesterase. This enzyme just chews it up quickly, which is why its effect is so short. The leftover bits are then cleared by the kidneys.
So plasma enzyme is key for succinylcholine. What about, say, rocuronium?
Rocuronium is mainly handled by the liver. It gets metabolized there. And then the breakdown products plus some unchanged drug get excreted mostly into the bile.
Liver and bile for rocuronium and cisatracurium. The notes mention something unique. Hoffman elimination.
Yes. Cisatracurium is different. It undergoes Hoffman elimination. This is basically a spontaneous chemical breakdown that happens in the plasma and tissues just at normal body pH and temperature.
So it doesn't need the liver or kidneys to break it down?
Exactly. It's organ-independent metabolism. The breakdown products then get cleared mainly by the kidneys, but the breakdown itself doesn't rely on organ function. That's a big advantage, as you can imagine, in patients with kidney or liver problems.
That is fascinating. Just breaks itself down. Okay, let's put some numbers on this with pharmacokinetics. Onset, duration, metabolism, excretion for these key players.
Right, so succinylcholine. Onset, super fast, 30, 60 seconds. Duration, super short, 5-10 minutes. Metabolism, plasma cholinesterase. Excretion, urine.
Quick in, quick out, rocuronium.
Rocuronium. Onset, still pretty fast for a non-depolarizer, 60-90 seconds. Duration, much longer, 30-60 minutes. Metabolism is hepatic, so liver. Excretion mainly via bile.
Longer duration liver bile, got it. And cisatracurium.
Cisatracurium. Onset, a bit slower, maybe 2-3 minutes. Duration, similar to rocuronium, around 45-60 minutes. Metabolism is that Hoffman elimination we just talked about. Excretion of the breakdown products, urine.
Okay, seeing those times side by side helps. Now let's get really practical. Clinical pearls. What are the absolute must-knows when using these?
Okay, huge one for succinylcholine. Do not use it if the patient has hyperkalemia, high potassium levels.
Why not?
Because succinylcholine itself can cause potassium levels to rise, maybe by 0.5 to 1 mMeq. If the patient's potassium is already high, pushing it even higher can cause, well, dangerous heart rhythm problems, even cardiac arrest. It's a major contraindication.
Wow, okay. Definitely file that one away. What about a key pearl for cisatracurium? You mentioned its metabolism.
Right. Because of that Hoffman elimination, its organ-independent metabolism, cisatracurium is often the preferred choice, the go-to agent for patients who have significant kidney or liver failure.
Because its duration won't be unpredictable in those patients.
Exactly. You take the variability of poor organ function out of the equation for its breakdown. Safer, more predictable.
Makes perfect sense. Okay, but nothing's perfect. Let's talk adverse effects. What can go wrong?
Yeah. Definitely things to watch out for. Cardiovascular effects, for instance. Succinylcholine can sometimes cause bradycardia, slow heart rate, probably vagal stimulation.
Okay.
And atracurium, another benzylisaquinoline like cisatracurium, but less commonly used now. That one's known for causing histamine release, which can lead to hypotension, low blood pressure.
How do you manage those?
Well, for bradycardia, maybe atropine. For hypotension, fluids, maybe pressors if needed.
Got it. What about breathing, respiratory issues?
A big one is prolonged apnea, meaning the patient doesn't start breathing again when you expect them to after the drug wears off.
Why would that happen?
With succinylcholine, it can happen if the patient has a deficiency in that plasma cholinesterase enzyme. They just can't break the drug down effectively.
Ah, the enzyme we talked about earlier.
Right, so the paralysis lasts much, much longer. Management is basically supportive, keep them on the ventilator until they recover function.
So monitoring is key there. Any specific muscular side effects?
Yes, the most feared one. Malignant hyperthermia, or MH.
Right, MH. Heard of that.
It's rare, but potentially fatal. It's a genetic susceptibility thing triggered by succinylcholine, often combined with certain inhaled anesthetic gases.
What happens in MH?
Basically, an uncontrolled, massive increase in muscle metabolism leads to skyrocketing body temperature, intense muscle rigidity, acidosis. It's a hypermetabolic crisis.
Sounds terrifying. How is it treated?
Immediate treatment is crucial. The antidote is dantrolene, given Mefario, plus aggressive cooling, supportive care. You have to act fast.
Dantrolene for MH. Got it. Any other reactions like allergies?
Yeah, allergic reactions, even anaphylaxis can happen with any of them, theoretically. Rocuronium seems to have a slightly higher reported rate of anaphylaxis compared to some others. Might be IgE-mediated.
And the treatment for anaphylaxis?
Standard stuff. Epinephrine first, then steroids, antihistamines, supportive care.
Okay, so range of potential issues. Which leads us nicely into contraindications. When should you absolutely not use these drugs?
Right. There are absolute contraindications, definite no-goes. A known personal or family history of malignant hyperthermia is an absolute contraindication for succinylcholine and volatile anesthetics.
Makes sense, given what we just discussed.
And as we stressed earlier, hyperkalemia is an absolute contraindication for succinylcholine.
Okay, MH and hyperkalemia for 6-case. What about relative contraindications, where you need to be really careful?
Well, known pseudocholinesterase deficiency is a relative contraindication for succinylcholine because of that risk of prolonged paralysis.
Right.
And in patients with myasthenia gravis, that autoimmune disease causing muscle weakness,
Yeah.
you need to be very cautious with the non-depolarizing agents. They can make the weakness much worse. You'd use them very carefully, probably at much lower doses, if at all.
Okay, good points. Now, how do these drugs play with others, drug interactions?
Oh, yeah. Several important ones. Certain antibiotics, specifically the aminoglycosides like gentamicin or tobramycin, they can actually potentiate or strengthen the neuromuscular blockade, make it last longer or be deeper.
Good to know. Anything else?
Magnesium sulfate, used sometimes in preeclampsia, for instance, that can also enhance the blockade from neuromuscular blockers. Again, risk of prolonged effects.
Okay, so watch out for aminoglycosides and magnesium. What about drugs used to reverse the blockade?
Right. So for the non-depolarizing agents, we often use cholinesterase inhibitors. Neostigmine is the classic example.
How do they work?
They block the enzyme that normally breaks down acetylcholine. So more acetylcholine builds up at the junction, and it can then outcompete the non-depolarizing blocker for the receptor sites, restoring muscle function.
Clever. Fighting fire with fire, almost.
Kind of. But neostigmine can cause side effects like bradycardia, so you usually give it with an anticholinergic like glycopyrrolate to counteract that.
Neostigmine plus glycopyrrolate. Okay. Now, there's a specific exam tip here in the KMR Advised Notes about reversal.
Yes. Super important. Shigamidex.
Shigamidex.
It's a newer reversal agent, and it's very specific. It only works for rocuronium and vecuronium, those aminosteroids we mentioned.
How does it work?
It's really neat. It actually directly binds to the rocuronium or vecuronium molecule in the plasma. It encapsulates it, forming a tight one-to-one complex.
So it just grabs it and takes it out of action?
Exactly. Pulls it away from the neuromuscular junction, making it inactive. This leads to really rapid and predictable reversal. It's a big deal, and definitely something you following on KMR Advised need to know.
A Shigamidex for rock and vec. High yield.
Okay. Let's touch on dosage and maybe some related clinical pearls.
All right. Succinylcholine for intubation. Typical IV dose is 1 to 1.5 milligrams per kilogram, but remember, avoid if there's any MH risk.
Got it. Rocuronium for intubation.
Usually 0.6 to 1.2 milligram IV. And if you need to reverse it quickly, Sugammadex dose is typically 16 milligram IV for immediate reversal.
Okay, and cisatracurium. Initial FIDE dose is often 0.1 to 0.2 milligkilograms. If you need to maintain the blockade, say for a longer surgery, you might give maintenance doses of around 0.03 milligkilograms every 20 to 45 minutes or so, depending on monitoring.
Good benchmarks to have.
Yeah.
Now, a specific pediatric note here about succinylcholine.
Yes, this is critical. There's a known link between giving succinylcholine to children and the risk of rhabdomyolysis muscle breakdown.
Rhabdo, wow.
Yeah, and the risk is especially high in kids who might have an undiagnosed muscular dystrophy. Because of this risk, succinylcholine is generally avoided for routine use in kids. It's usually reserved for real emergencies where you absolutely need rapid airway control and have no better option.
Very important distinction for pediatric patients.
Yeah.
Okay, what about toxicity and management if things go wrong?
Well, the main sign of toxicity, broadly speaking, is that prolonged paralysis we talked about. The patient just isn't recovering muscle function as expected.
And management?
Primarily supportive, keep them safely ventilated, check and correct any underlying issues like electrolyte problems that might be contributing.
And for malignant hyperthermia specifically, we mentioned dantrolene.
Right. If you see the signs, the high fever, rigidity, acidosis, it's an emergency. Dantrolene, 2.5 milligVOQ IV stat, plus aggressive cooling, managing the acidosis, supportive care. It's all hands on deck.
Definitely sounds like it. Okay, let's quickly cover the black box warnings and recap some keynotes.
Okay. Succinylcholine has that black box warning about the risk of hyperkalemic cardiac arrest, particularly in kids with undiagnosed muscle issues or patients with burns, denervation injuries causing rhabdo.
Yeah.
Rocuronium has a black box warning about the risk of anaphylaxis, noting it might be a bit higher with aminosteroids generally.
Okay.
And while maybe not always a black box, remember atracurium and histamine release, be cautious in asthma patients.
Good safety reminders. And a key high-yield fact to hammer home.
Yes, worth repeating. Sugammadex only reverses rocuronium and vecuronium. It does not work for succinylcholine or the benzylisaquinolines like cisatracurium. Your reversal agent choice depends entirely on the blocker used.
Crystal clear. Okay, let's wrap up with a final exam checklist. The absolute key takeaways for everyone following on KMR advice.
Perfect. So for your review, first, nail the mechanism of action difference. Depolarizing, Sux phase 1 versus non-depolarizing, ROX cis phase 2 competitive block.
MOA difference, got it.
Second, know the key drugs. Succinylcholine, fast intubation, short duration, depolarizing. Rocuronium, fast non-depolarizer onset, aminosteroid, Sugammadex reversal, cisatracurium, benzylisaquinoline, Hofmann elimination, good for organ failure.
Key drugs and their features.
Yep. Third, contraindications. Remember MH risk, especially Sux, hyperkalemia, absolute for Sux, pseudocholinesterase deficiency, prolonged to Sux effect.
Contraindications. Crucial.
Fourth, reversal agents. Sugammadex specifically for ROC and VEC, neostigmine plus glycocurylate usually for other non-depolarizers. Nothing reverses succinylcholine directly except time and plasma cholinesterase.
Reversal strategies.
And then finally, that clinical pearl, pseudocholinesterase deficiency causing prolonged paralysis with succinylcholine. Understand why that happens.
Great summary. Really hits the high points.
Master those, and you'll have a really solid foundation on neuromuscular blockers for your exams and practice.
Excellent. Well, that wraps up our deep dive into neuromuscular blockers. Really essential drugs in so many clinical settings.
Absolutely.
We really hope this discussion, walking through your neuromuscular blocker essentials document, has helped solidify things for you. Remember, you can always refer back to your uploaded notes and this discussion on the deep dive alongside KMR advice to reinforce your understanding.
And let us know, are there other pharmacology topics or related areas you'd like us to tackle in future deep dives on KMR advice? Drop a comment below.
Yeah, we'd love to hear from you. And if you found this helpful, please give it a like, share it with your friends and colleagues, and definitely subscribe to the KMR Advised YouTube channel.
And don't forget that bell icon. It ensures you get notified about all the new educational medical content we put out in this format.
We look forward to exploring more fascinating topics in pharmacology with you next time, right here on KMR Advise.